This is Heart Rhythm TV. I'm Roderick Tung. In this month's featured article, I am joined by Auriane Ernault and Ruben Coronel from Amsterdam at the University Medical Center. Welcome, Ruben and Auriane.
Hi.
Thank you.
The real question here is, does epicardial adipose tissue have direct arrhythmogenicity? And in this really interesting experiment, you examine the secretome of the atrial epicardial adipose tissue and see if it facilitates myocardial remodeling, the action potential, and potentially atrial fibrillation. Take us through a little bit about this line of questioning and why your group has been interested in the role of epicardial adipose tissue in atrial fibrillation.
So indeed, there is a clear link between excess adiposity, epicardial adipose tissue, and atrial fibrillation. And this can be explained by the fact that in overweight, visceral adipose tissue tend to accumulate around internal organ and as well as around the heart. So the epicardial adipose tissue, which is a type of visceral fat that can be found subepicardially between the myocardium and the epicardium, has gained a lot of attention recently, and it is suspected to play an important role in the development of the substrate of AF. So what we know so far about epicardial adipose tissue and AF, thanks to observational study and meta-analysis, is that the epicardial adipose tissue volume is associated with an increased incidence, duration, chronicity, and recurrence of AF after ablation.
And for the clinician, we always think that that might be because of other risk factors that are associated with metabolic syndrome, like sleep apnea, pulmonary hypertension, systemic hypertension. But this line of questioning is really about whether there's a direct modifiable pathophysiology that underlies atrial fibrillation.
It is, and it's all independent from all comorbidities. So it seems like the more volume and the more risk of incident AF, but also of the persistent AF. And there are several potential mechanisms for that. So the first mechanism is more structural. So we think that when the epicardial adipose tissue infiltrates within the myocardium, it results in heterogeneous propagation of the sinus impulse, and that facilitates AF. But what we are more interested in this research is the paracrine effect of the epicardial adipose tissue, because it was shown that the epicardial adipose tissue secretes, for example, activin A and profibrotic factors. So in addition to that, we show that it not only increases fibrosis, but it leads to electrical remodeling of the myocardium.
And Auriane, can you go ahead and just take us, the viewer and the reader, through this figure with your experimental setup?
Yep.
Yes. So to understand the effect of the mediators that are secreted by the epicardial adipose tissue, we collected both epicardial and subcutaneous adipose tissue from atrial fibrillation patients here in the Amsterdam UMC. So those patients were undergoing surgery for ablation. So we collected both the adipose tissue type, and then we dissected this adipose tissue and collected the secretome. So we incubated the tissue in culture medium for 24 hours, and at the end got the secretome. And then we needed a cardiomyocyte for incubation. So for that we use neonatal rat, because they have the ability to be cultured for several days without remodeling. So we use that model, and we incubated those cardiomyocytes for 3 days with the secretome. So that's what you can see in the panel A. And then at the end of these 3 days, we performed electrical mapping. That's what you can see in the panel B. And thanks to culturing the cell on microelectrode array, which have glass and gold electrode at the bottom, we can reconstruct activation map. And that's very important information for us, because without this electrical mapping, we cannot tell anything about conduction velocity. So we show that the secretome of epicardial adipose tissue, but not of subcutaneous adipose tissue, slows conduction in this NRVM, in this neonatal rat monolayers. And what you can see below the activation map in panel C and D is the quantification of the conduction velocity and heterogeneity. So we also observed that conduction was slower and more heterogeneous. And when we performed microelectrode recording on these monolayers, so panel E to J, we observed depolarization of the resting membrane of cardiomyocytes. So there were changes at the cellular level that could explain what we saw on the conduction velocity.
Well, this is fascinating. Taking a human atrial adipose tissue, extracting its secretome, potentially having pro-inflammatory cytokines, adipokines, it modifies the action potential heterogeneity, slows conduction. And then you go ahead and take a look at some potential modeling of how that could then create a re-entrant milieu in the left atrium. Can you take us through figure 5?
Yeah, we used a atrial model, a human atrial model in silico. You can see it on the top row. And we applied the changes we have seen in the cells, in the NRVMs, to this model. So we introduced a small depolarization, and this caused a conduction slowing. And we applied various amounts of EAT in this model, indicated by the red dots that you see, and it's almost confluent in the right panel where you see EAT 75%. So 75% of the atrium is covered by EAT. And then we try to induce arrhythmias in those models by premature stimulation. And at EAT 0, you see only the paced beats without arrhythmia following it. And only at EAT 50 and 75, you see that there is a sustained or a single premature beat, a re-entrant beat at 50, and a sustained atrial arrhythmia at 75% of EAT. So this confirms that the conduction slowing contributes to increased risk of re-entry. And interestingly, we don't show it here, but at EAT 100%, this effect was gone. So the heterogeneity induced by the EAT is needed to induce re-entrant arrhythmias.
Well, thank you, Ruben. So now in Europe, you have almost 1 out of 3 people suffer from obesity. In America, we have 1 out of 2, and 2 out of 3 are overweight.
Yeah.
What does this mean for us clinically?
Yeah, there are several implications of this study for clinical cardiology. First is diagnosis. I think based on the amount of EAT, we should be able to risk stratify patients for whether they are at risk for atrial fibrillation. And secondly, there's a therapeutic implication. I think you're alluding to that. Of course, body weight reduction is one of the main things that can be achieved, and it should work against atrial fibrillation if this is correct. And secondly, you could think of ablating the epicardial adipose tissue during surgical or catheterization procedures.
So this would almost be like liposuction during cardiac surgery and potentially removing epicardial, or with a medication or weight loss, the regression of this tissue may decrease the burden of the secretome.
Exactly. If we can identify the component of EAT that causes this, then we can develop antagonists, for instance.
And there have been studies, as you know, as well, that looking at EAT thickness and recurrence after atrial fibrillation ablation as well.
Yes. Yeah.
Well, congratulations on a wonderful, insightful experiment and manuscript. We're delighted to highlight this for the Heart Rhythm Society and our readership. Keep up the great work, and thank you for joining Heart Rhythm TV.
Thank you.
Thank you very much.